Welcome back to the Tracheostomy Care Bite-sized series. In part 3, we're going to be talking about emergencies. So the aims of the session are to look at red flags or the things that might lead you to suspect that there's a problem with the tracheostomy tube, and what types of emergencies occur as a result of a tracheostomy tube. Don't forget, your patient with a tracheostomy tube should always have one of these bed heads at the end of the bed, and these can be downloaded from tracheostomy.org.uk. And if they have a laryngectomy, this bedhead can also be downloaded from tracheostomy.org.uk. So let's just review tracheostomy tubes once again, and we've got a picture of a cuffed tube here, and on the blue pilot cuff we can tell that the internal diameter is 8 millimeters. Tracheostomy tubes come these days with inner tubes, the clear one with no holes or fenestrations, and the red one with holes or fenestrations that allow air to pass up and through the voice box in which to allow the person to speak. So it's important to know what you need at your bedside to make sure that things are safe, and what you'll need is wall oxygen that works, suction that works, and you should check this at the beginning of each shift, suction catheters of the correct size, sterile water, a Yanker suction device and some suction tubing, some pulse oximetry, and the correct PPE. And in these days of COVID, we need to make sure that we're wearing the correct PPE for aerosol generating procedures. Also, what's required is a clinical waste bin and a tracheostomy trolley. Now, these are available in lock wards, along with the emergency tracheostomy box. So every patient with a tracheostomy tube in situ must have one of these boxes at the bedside. So here's the equipment needed in your tracheostomy box. 2 spare tubes, one the same size and one smaller, to allow your help to reinsert in an emergency, and some tracheal dilators that should be in a sterile pack to help with this. Also a non-fenestrated inner cannula, that's the clear ones, a suture cutter because some tubes may be sutured in, a 10mm syringe to inflate the cuff, and a stocked and regularly checked resus trolley. And it's important to know where these boxes are kept in stock in the hospital, and that will be lock ward. So if you need one, then call lock ward to provide you with one. So what are the common tracheostomy tube emergencies? Well, the tube can be partially or completely blocked, and it can become displaced. The cuff may be leaking, so a failure of the pilot balloon to inflate the cuff itself. The patient may have a cardiac arrest, and the tube could fall out completely. So what are the things we need to consider when we suspect that the tracheostomy tube is a problem? Well, like any assessment, we should always start with A for airway, and with tracheostomy tubes, they are our airway. It's important to remember with tracheostomy tubes that there is an upper airway to consider above the tube itself as well as the tube, and with a laryngectomy there is just the one airway. Patients with tracheostomies can become unwell and show signs of problems that other patients get too, so it can be easy to become fixated with the tube itself. So if the patient's got a cuffed tube correctly sited in the trachea, no gas should escape through the mouth. If the person's talking to you, or you can hear audible air leaks or bubbles of saliva are seen or heard at the mouth and nose, then gas is escaping past the cuff, and This probably implies that the cuff is damaged in some way, or the tip of the tube is not correctly sited in the trachea. Though grunting, snoring and stridor can also be signs that there is an airway problem. You will also see some red flags associated with breathing. So the patient may be apneic. They may have difficulty in breathing, which the patient may report to you or you will observe clinically. Use of accessory muscles of breathing with a high respiratory rate. And if they're ventilated, they'll have high airway pressures and lower tidal volumes. They'll be hypoxic, as seen by your saturations and the patient's colour. And they will have noisy breathing. So there could be red flags associated with the tube itself, and looking closely at the patient, you may see that they have a visibly displaced tube with it poking out further than it was before. There could be blood or bloodstained secretions around the tube, particularly in a recently performed tracheostomy or one that's been changed. If you're worried at all, you should seek help to get it assessed immediately. The patient may report increased pain or discomfort, or you might find that you're frequently having to inflate the cuff because you keep hearing a leak, and this will tell you that the cuff is damaged or that there's an air leak, which means that it ultimately needs to be replaced. The tube may also require the cuff to be inflated to keep the seal because it may be partially displaced, in which case, again, you need to get it assessed as soon as possible. There are also general red flags, and these are physiological changes that tell you about most people that are unwell. So particularly from your assessment, you'll notice changes in respiratory rate, heart rate and pulse, blood pressure, and changes in level of consciousness. Particularly with these patients, they may show an increased level of anxiety or restlessness, which may indicate an airway problem with the tube itself. So here we see a couple of pictures. On the left, a partially displaced tube where the tube does not sit all the way down the trachea, or a completely displaced tube where it's sitting outside the trachea. In both instances, you will not be able to pass the suction catheter as far as you had been used to. So the ways to tell whether you've got a partial or complete tube displacement are that you get resistance when you're trying to suction despite a clear inner cannula. Some obese people with thick necks are much more likely to displace the tracheostomy tube because they've got more soft tissue in their neck. Or the patient could have a pneumothorax or air in their mediastinum or surgical emphysema. If you suspect an issue with a tracheostomy tube, you need to seek support immediately, either from anaesthetics or critical care outreach. And because this is an airway problem, it is a medical emergency. So dial 2222, state your location and medical emergency. So there's three main sources of cuff failure in cuff tubes. The first is leaking of air within the cuff. So perhaps something sharp got stuck in it, making a hole during insertion, or there's a misplaced nasogastric tube if the person has one in situ, or less commonly, a defective tube itself. There may be a leak around the cuff, so it's not fully inflated, or the cuff is inflated, but the tube's too small. There could be leaks associated with the patient's position, or the trachea may have become weakened and soft due to very high inflation pressures in the past. And that underlines the importance of checking cuff pressures regularly. There could be this pistoning effect, and pistoning just means the movement of the tube up and down constantly. Which is why we should take care to secure these things firmly and not too loosely. So in an emergency, it's important not to panic because you have emergency management algorithms at your disposal, and these can be downloaded from tracheostomy.org.uk. The one on the left in green is for tracheostomy patients, and on the right in pink is for laryngectomy patients. So first of all, you want to look, listen and feel at the mouth of the tracheostomy tube. You will not have a water circuit available on the wards at Princess Alexandra Hospital, but a bag valve mask will do just as well. First of all, is the patient breathing? If no, and there's no pulse or signs of life, then call 2222 for cardiac arrest. If they are breathing, then apply oxygen to both the face and the tracheostomy, and then assess the tracheostomy patency by passing a suction catheter. Just remember, if they have a speaking valve or cap, you'll need to remove these first. If you can pass the suction catheter, then the tube is patent, but it may be partially displaced or there is a partial obstruction. If you can't pass a suction catheter, deflate the cuff and look, listen and feel at the mouth of the tracheostomy. If the patient's improving, continue your ABCDE assessment until the team arrives, by which time they will have already, even if they're not improving. For a laryngectomy patient, the process is fairly similar, so check again, is the patient breathing? If not, and there's no pulse present, then call for cardiac arrest. If they are breathing, then apply high flow oxygen to the laryngectomy stoma first. If you're in any doubt whether the patient has a laryngectomy, apply oxygen to the face also. Then assess the laryngectomy stoma for patency. Most stomas won't have a tube in situ, but if it has a cover, then remove that. And if there is a tube, then remove that also. And then try and pass a suction catheter. If you can, the stoma is patent, but continue your A to E assessment. If you can't pass a suction catheter, look, listen and feel at the laryngectomy stoma and continue your A to E assessment. If you've called for expert airway help at the beginning, they will have arrived. We're unable to embed the emergency management algorithm videos from tracheostomy.org.uk. However, we strongly suggest that you go to the site, follow the links and watch them yourself. They're very short and they're excellent exemplars. And once again, as a reminder, it's important to know if your patient has a tracheostomy or a laryngectomy. So we're at the end of the Tracheostomy Care Bite-Size Series Part 3. Don't forget to head over to tracheostomy.org.uk where you've got access to some great e-learning that's free and you can use that for revalidation for the nurses out there. Algorithms and bedheads can be downloaded from there as well, and there's also access to their videos. So they've got some very good videos on what to do for emergencies, for tracheostomy tubes and laryngectomies, and they're excellent exemplars of what to do.